You're very welcome. In the morning we had a more general approach. In the afternoon sessions here and there, it will be more lively or more concrete. So myself, my name is El Salembier. I am involved in an educational center in the Gambia, West Africa. But today we are very lucky to have those nice ladies here to listen to. And it will be mainly on health education for children and youths from various points of view. So our first speaker will be Lieve Adam, and Dr. Jolien Laarmans will flop in afterwards, and then after that we will hear Dr. Monica Arora, who is from India and who will explain from her experience there on the kids materials, right? Okay, so I'm not going to introduce too much of the speakers as far as you could read already in advance, and I think it's more interesting if we can listen to themselves.
Okay. Good afternoon, everybody. I hope you're sitting well. You have had a nice lunch. Thank you, Els, for the introduction. I'm Lieve Adam. I'm working for Red Cross already a long time, and I'm focal point first aid for international cooperation. So I was saying I will take you with me on a journey on first aid education. But before I do that, I will show you, we'll go also to first aid in Africa. But before we do that, I want some questions to ask to you on first aid. But I kindly ask you, could you please stand up? When I ask the question, please stand up. I do it myself also. Thank you. My first question is, of course, related to first aid. And my first question is, did you ever deliver first aid in a public area? If you didn't, please sit down. If it's positive, please stand up. Which? Oh. So these people, they already delivered some. Yeah, if you doubt, you stand up. No problem, no problem. My next question is, in your workplace, where you work, do you know where is the first aid kit? Oh la la. You stand up again. It's okay. That's good. Yeah, that's good. There is no first aid.
What do I do?
At least you know.
You know that there is.
At least you know there is.
Okay. If you don't know it, please tomorrow morning go and check it, because maybe you will need it in the afternoon. Last question: did you ever witness a child delivering first aid to somebody else? Did you ever? A child? Oh, no. Okay, we come back to this. Thank you for the cooperation. So as I told you, I will tell you a little bit on first aid education, and Jorien will continue by explaining how we make some materials, but I come back to this. What I will give you is a little bit Red Cross. I'm from Belgium Red Cross. Why we do first aid. I will come back, why exactly do we first aid? It's nice, why we do that as an organization, and what is Belgium Red Cross has to do with it. Then I go into Belgium Red Cross Flanders programs internationally, where we use contextualized material linked to capacity building programs. And by the end of, we are talking about first youth materials for first aid, and then Jorien will come in. By the end, I hope, we can have it a little bit more in detail on the challenges, and especially interested in challenges we have to put first aid in the school curriculum. Maybe the challenges we do it afterwards, I don't know, we will decide. But for sure you will have time to ask many questions, and we hope we have some answers. Starting, we are the International Red Cross and Red Crescent. We are a worldwide organization, very huge. I think everybody knows it, I think. And we are known to be the first responder in case of emergencies, in case of war, in case there is something happening. You can see people with a Red Cross or a Red Crescent. So we're worldwide and active in 191 national societies. First aid is a core business. It all happened. Maybe some people know it. Henri Dunant, he walked to Solferino. He saw the people suffering on the battlefield, and he helped them. So helping And then first aid, it's really a core business of our national societies. I will not go into this because then it will take all afternoon, but it is really our core business. And the next thing I want to say, we are really known for the last mile, meaning that we have volunteers all over the world into the community. So we are really dispersed all over a society, and when we teach or we learn or we train or we involve volunteers, they are part of the community. So if we have to deliver some services, we are lucky because they are already there. So we have a good chain of delivering services. So we are known for that, and I think it's really an asset from Red Cross. Why first aid and first aid training? It's a low-cost opportunity to decrease the burden of disease and injury in sub-Saharan Africa. I didn't say it like this, but the World Bank said it like this. They make some investigation and some research, and it's known and proven that you can, in your investment in health, if you put it in the low cost, like first aid training, you can have a huge impact on well-being on healthy communities. Why is Belgium Red Cross doing first aid? We have I already wanted to say again, huge national experience. We have a good national experience on delivering first aid and first aid services. We train people in Belgium. We are really specialized in good didactical manners to teach people in the communities. Besides that, also Belgium Red Cross was on the foundation on the developing of the first aid and resuscitation guidelines. These are guidelines, this is the Bible, how you have to practice first aid. These guidelines, people all over the world, and mostly in the northern Western countries, they use this to make their manuals, their instructions for volunteers, for trainers. So these international guidelines, they are from the International Federation, and it's the Center for Evidence-Based Practice of Belgium Red Cross, who also was involved in the developing of these guidelines. So we have two ways to be extra involved in first aid. And we are doing first aid, I think, since 2000 in Nepal, in a southern project. So we have also some commitment and long-term experience in building up first aid capacity in other national societies. The Belgian Red Cross first aid programs, like I told you, we are working in the south, and mainly in African national societies, and in Asia, it's mostly Nepal. And what did we see? We could find out that in Africa you have no contextualized material. In fact, you have no material to teach first aid. We could see that most of the countries, they use the British Red Cross manual or the French Red Cross out of the colonial time. And nothing wrong with this, but this is not up to date. If I talked about the international resuscitation and first aid guidelines, they are revised every 5 years. So if you have to make some reanimation and you have to do it 30 times or 2 times or 28 times, it's revised every 5 years. And then you have instructions. So you can find in Africa good first aid, but somehow outdated, and using the methodology of 20 years ago or maybe even older. So we saw it, and then also Belgium Red Cross decided to make these international resuscitation guidelines, to make them contextualized to Africa. So we did our own research with the Center of Evidence-Based Practice to see what kind of guidelines or what kind of instructions for first aid is accepted and adapted to the context of Africa. And there it all starts. We made the contextualized manual and guidelines for Africa, for Nepal, and also for India. Meaning, if you have guidelines, you have material that they can use to make their own manuals and their own posters and their own material to train. This is to give you an idea how much how many countries are using effectively the contextualized material. When I'm talking contextualized material, I want to to give you an idea what exactly is it. These guidelines, we call it AFAM, it's a shortening saying African First Aid Materials. They are really made by Africans and for Africans. So they are the expert group, and the way, the methodology, how it is made, you can have it more in detail when Jorien will have her expose on really the making of evidence-based material. We are focusing on up-to-date first aid techniques. I already told you. We will also introduce injury and disease prevention, because we thought, or the African experts advised us, you have to include that in the first aid. That as well as you say what to do with diarrhea, that as well you say how to prevent the diarrhea. And then you come to hygiene and wash, and it's included in our manual, in our guidelines. The content is adapted to the context, meaning that, for example, you can have a burn, and research and evidence research and good practices showed that in Africa, it's a good practice to cover your wound, your burn, with cold honey. And in another case, also even aloe vera. You will not find this in a first aid manual in Belgium. But in Africa, we can advise the people, if you have nothing else, of course, if you have nothing else, then you can cover it with cold honey. It will prevent infection. Another example is, we always say you have to protect yourself if you do first aid. Yeah, you put on gloves. You can imagine that you are in the field in Malawi, no gloves available. And then we advise, as an instruction, if you have no gloves, please use clean plastic bags. Then you see contextualized. In Rwanda, we had to skip it, because in Rwanda, you are not allowed to use plastic bags. So we try to find some solution in countries, even if the material is available, but also that they can have it regionally where it's not available. These booklets, we make books of it, or instructions from it. They are classified in a very simple, easy way. The last one, we make it emergencies, injuries, and illnesses. So it's good categorized, so that's easy to use. Also, we use the fact that you make a classification on the signs, the symptoms that they can recognize. Most of these instructions are made like, what do you see, what do you do, how you give first aid. And it's always repeated like this. So good observation, what you can do, and how you give in a good manner first aid. We make it very simple instructions. It's also that not too much language. Not everybody can read and write, but that at least the trainer has very clear and simple instructions. We choose, or the people who developed it choose to make very clear drawings, but the purpose was that you can copy it very easily. And then text, we made some illustrations. Text and illustrations are made from different, for youth, for women, men, elderly, people from different ethnic and different religion, you can find in the manual. We have this material in English, French, Portuguese, and now very recently we are testing the Swahili one. So we could see that we have to translate it to local languages, or even if it's the small guideline or the small instruction, even it's a boîte à images, picture box, that you can make it in a language that they can understand. Here you see some examples of these drawings. We revised in 2017. We let the material revised by a gender specialist. So again, we changed some drawings. Especially, we changed that we put a lot of female drawings to help, that they are in the position of the helper and not only the victim. So that we have a balance, and that it's shown, even it's sometimes not allowed in the context, that it's shown that they can also help and not only wait and see and not touch. And the challenge on this one. So this is a kind of material that we made, and in fact it was meant for all these national societies in Africa to use it and to have it ready to use, the pictures, the text, the guidelines, everything. They could make their own personal country manual. Unfortunately, what did we see? Some of them did it. Like this is an example in Burundi. We had this material. They got the pictures, all the basic elements, and they remade it, and they made their own picture. For example, in Burundi, they wanted to make very, very nice paintings and showing how Burundi looks like, and that's their manual. So that was, in fact, the intention, that they could adapt the material to their own way of formulating or printing or modeling the material. But we could see that after we did all this effort and this good contextualized material, that I think only 6 countries really made something of it. How come? Of course, we make an evaluation. Mostly we can see if you have not the resources, not the capacity, and you are not supported, you have not the intention to really use this fantastic material, or it's hindered. So in the countries where we were doing capacity building or where we were working, they made a huge progress in developing posters or their presentations, but not in all the countries who were involved in this, where we spread it. I think 29 countries took the license. We spread it to national societies with a license, for free, of course, but even then, even with an implementation guide, it was not used, unfortunately. So what we did now in 2017, we handed over some ready-to-use material. So at least they have one booklet manual. I think you could see it in the launch there. That they can use. It's a manual ready to use to give basic first aid. 16 hours, 24 hours. But in this basic first aid, you can find all the instructions that you have to deliver for a certificate for basic first aid. So that's a choice that we made, that they can have it ready to use, kant en klaar. What we also noticed is giving only fantastic material, it's not enough. I don't know your experience, and I'm curious to know, all of you, what you think about this. But we could see that if you want to deliver a quality first aid training, that you have to support them with additional skills to train. And I can assure you, first aid, we have very, very good first aid trainers in Africa. They know how to do that. They are very good trainers, but the most of them, they are also teachers somehow, they are used to do lecturing. And if you only lecture in first aid, especially in first aid, you can never be a first aider at the end. You have to practice, you have to have an interaction, you have to know what you are doing, and a rehearsal, and really practice the techniques. Otherwise, you go out of class and you don't know how to do it in the road. So, saying this, we will always combine this kind of delivering contextualized material to teaching and skill development. And I come then to the fact that we link always this kind of support, technical support, to the capacity building program. Meaning that we are trying that the first aid service of this country, a first aid training service, let's say, that they can develop themselves. We start, of course, I think most of the development programs work like this. We put some input in the master training, and then we guide them, or we support them, that they can deliver themselves new trainers, and that the trainers can, of course, themselves deliver first aid to lay people or to volunteers. So that's the chain. What we do then exactly, we support the master training. Sometimes from expertise from Belgium, but even it can be from the south, that they give each other the master training using this contextualized material, using the last standards, using the up-to-date information. We give them also material to teach well, also to give first aid. Otherwise, you have a good trained first aider who can not really deliver first aid because he has no material. And finally, we really put some effort in institutional development, meaning that the management system to organize these trainings, to be to monitor and to see if the standardized material is well used. All this we put in a program as a package and not only to give manuals. Here you see some active volunteers. Nice to know, or what was nice, especially for me to know, we worked long time in Nepal and we trained many volunteers. And then there was the earthquake. And one of the reporting said very clearly that most of the communities, they were helped directly after the earthquake by good trained lay people, not even volunteers, but then lay people and volunteers, they're all part of the community. So they were there when the earthquake struck. So that's nice, you can train them and then you see the results. But now, what about children and first aid? I could see that nobody has ever seen a child delivering first aid. So I'll let you hear something. Hoe moet ik dat doen? Oh.
No, please, what is your emergency?
Hello, I'm Roman.
Okay, where's your mummy?
She's at home.
And where are you?
At home as well.
Can you do me a favour? Can you go and get mummy?
We can't, she said.
You said mummy was there. What do you mean she said?
It means that she's closing her eyes and she's not breathing.
Right, so do you know where you live?
Row 22.
Can you go to your mummy and shake her for me?
She's not waking up.
Give her a good shake. Shout out, mummy.
Mommy! It didn't work.
Are you in Kenley?
Yes, Henry.
What is your name?
Roman.
So, thanks to Roman, his mother is still alive. So we can teach children to do the essential or to learn them a little bit on first aid, and during all their career they will know what to do. Saying this, so we will now go into the first aid educational materials for youth and children that we are making. What we will do, what is it exactly, why we do it and how we do it, especially how we do it, and started with making the youth educational material. Jorien will explain to you. But like you see, also in this advertising, that children can really help and make the difference. If you train them, if you notice them with the basics of first aid, it can really make a difference. We were asking ourselves, but what exactly has you to teach to children? Because I can imagine in Belgium you can teach somebody from 8 years how to call, but can you do that in Africa? Can they call? Can they use a phone? Do we have to find another way of alarming? What exactly we have to teach them? Can they stop a bleeding? Is it possible in Africa? Or, is it not dangerous there? All these things, there were questions that we asked. And also, from what age? Can you learn somebody to do the reanimation when they are 12? Maybe 14, maybe 16. We have the experience here in Belgium, but anyway, we wanted also to know it, if there is any evidence on what we have to teach at what age in Africa. And especially I was interested how you teach it. Like I said, it's very important not only to give the package, but how you teach this. How is it possible to bring the message? Are we using games? Can you do that in Africa? My experience is they are not playing the same games, not all the same games as we. Can you use singing? Can you use a video? Is it not too abstract? Things like this, we were also wondering if it could be in the research and which educational materials should we use. But now I give the word to Jori.
Yes. So Leva came to me with these questions, and I was like, okay, interesting, let's do this. So how about these questions in Africa? She came to me because I'm at the evidence-based practice, the Center for Evidence-Based Practice from the Belgian Red Cross. So we are in fact a center that provides scientific support to all the activities of the Belgian Red Cross, including blood service, but also international humanitarian services such as first aid. So what is our principle? If you can help me with the video. The video. Yeah. I hope it won't be the same as the previous one because it was really slow, but I'll try.
Hello and welcome to this video about evidence-based practice.
I'm sorry, I will have to skip the video. I hope you're still awake. Everyone still happy to be here? Yes, okay, very good. So I can tell you that our drawing about evidence-based practice is also on YouTube. So since it's not working here, I want to advise you to look for Belgian Red Cross evidence-based practice, and then you'll find a lovely whiteboard drawing explaining all the principles of evidence-based practice. Now you have to do with my explanation, which is less, how should I put it? Entertaining. So, but I'll do my best at being as entertaining as possible. So, evidence-based practice is actually, the principle is based on 3 pillars. The first one is the collection of the best available scientific evidence. So it means that we look for existing studies and we look what is the evidence, what is actually the findings from these studies. We not only look at the evidence, but then we also include the practical experience and expertise of experts in the field. So in this case, it means that we went to Africa and consulted a lot of African experts in first aid and in education. And we also asked the experts, of course, what they know about the target group, because the target group of this guideline or whatever of these materials is in fact the people who are using the materials to teach the children first aid, but also the children who receive the training. So I will start off with the first pillar that we worked on, was to collect the best available scientific evidence. Now, I will not bore you with the very methodological way that we do that, because 1, it would take forever, and 2, it will also mean you're probably falling asleep, so I will skip that. If you want to talk nerdy with me, we can afterwards maybe do that. So, but in a nutshell, how does that work? First of all, we define a research question. What do you want to investigate? Then we develop a search strategy, which means it's a bunch of words we use to run through databases to find the studies on that topic. And then we start selecting. Sometimes there are 10,000 studies that we have to go through. Are these relevant or not? So we do a first selection. If we found the relevant articles, we will look through these data, of course, and extract what's relevant for us, what provides us the information on our question. We will also assess the quality of the study, because not all scientific studies are equal in quality. And then we synthesize, so we take together all the data and we form a conclusion that we can say, okay, all the studies suggest that this is working or this is not working. So the first question we asked was, at what age are children able to obtain a specific knowledge item, skill, or attitude concerning a first aid topic? Now, these first aid topics were the same as in the AFAM, so the African First Aid Materials for Adults. Among those are a general topic on hand washing, what is there in there? The use of gloves, etc. The main steps in first aid, it's about ensuring safety, how to alarm the emergency services, in this case medical community posts, but it was also on resuscitation, choking, skin wounds, burns, bleeding, and then injuries to bones, muscles, and joints, and poisoning. So these were based on the most important topics that have the highest burden of disease in Africa. Now, to give you an idea about the search for the first 8 topics, so the question, at what age can a child do what, obtain a certain knowledge, item, skill, or attitude, we looked for 11,446 studies, and then a lot of reading, a lot of scrutinizing, and finally we included 57 studies. So 57 studies that taught us at what age can a child do what or learn what. Now we decided to put it into an educational pathway. What is that? It's actually an overview of objectives that have to be achieved throughout different educational levels. I'll show you in a minute, but to give you an idea about the concept. So in fact, it means that key concepts are presented repeatedly throughout the curriculum, and they get more complex with each layer. Now, this is based on the spiral approach of learning, which entails that basic facts of a subject are learned first, and they don't have to worry about very complex details, but then as learning progresses, more and more details are introduced. So this repeating makes sure that it gets into the long-term memory of the students. So it's very small, I think, but this is the educational pathway. This is the example for burns. So you can see burns in the red bar. So on top you can see different columns, which are the different age ranges. So it's 5 to 6, 7 to 8, 9 to 10, until 17, 18. And then in the below, so on the left, you can see different objectives. For instance, I will read the first one. It's a knowledge one. The children recognize a burn. So that's an objective. You want to have the children recognizing a burn. From what age can you do that? So we made a pathway where we then first, so you have the E in orange. It's encouraging. It means that you can, as a teacher, you can introduce the topic, but you don't expect children to really reach this objective. However, when you look at the K, which is in green, I think, that's the age at which you expect a child to really obtain the objective. So you want them to recognize a burn at the age of 7 or 8. Now, the blue ones are the repeats, which means that you have to repeat it in your courses. So for the first one, recognizing a burn, it's until 13, 14 years, and we expect them to know it, to be able to recognize a burn at 13, 14 years. So we did that for a lot of objectives in both knowledge, skills, and attitudes. But then this was only, of course, based on the evidence, so only the scientific studies. You can also see that, in fact, the knowledge, the lower you go in the objective range, the more complex that it actually gets. You can see that it shifts towards older age, which means that it gets more complex with increasing age. And also that, in fact, the skills, knowledge, and attitudes are linked to each other. Sometimes it's at an increasing age, sometimes it's at the same age. So that was the educational pathway, only the evidence part. A second question Lieve asked us then was, which educational interventions are effective for teaching children, especially in sub-Saharan Africa? I will not go into the detail because it will take me very far, but to put everything together, we had 3 categories which we looked at. And the first one was, what if you provide instructional materials to children? For example, flip charts or textbooks. This was also in the school environment. So what if I go to a school and deliver them 10 textbooks on English or something? Do these children learn? Do we see better results on their English tests, for example? And we saw, in fact, that just the provision of these instructional materials does not really affect their learning, which is quite intuitively, I guess, if you just receive a book and you're not told what to do with it or how to use it, then it won't work. A second category we looked at was the use of alternative teaching methods, since Liv also said that there's a lot of lecturing in Africa. And we compared, so there were studies comparing the lecturing versus other interactive teaching methods such as group instruction, small group instruction, problem solving, cooperative teaching, etc. So more interactive ways. And it was shown that, in fact, all the studies confirmed that this more interactive teaching methods make sure that these children learn more in the end. So that's very good. I think that confirms what we all intuitively know. I think when you're more hands-on, that you learn more. And the third category was structured pedagogy interventions, which is actually a combination of both providing materials for children or for teachers, but also training the teacher how to use it, and also providing the materials themselves. So it's a combination, I guess, of the first and the second method, and we see that this is also very good and that it improves learning in children. Now, this is me and my best friend Einstein, at the airport of Frankfurt, I guess. He has a very nice quote, I think, and it tells everything. Information is not knowledge, and data without context is just organized information, which shows for me the importance of context, because now we have collected all the evidence, and it's nice, it's scientific studies. I like scientific studies because I'm a geek, but then is it contextualized enough? And I guess the answer is no, because in evidence-based practice, we look at the second and the third pillar, and that's why we gathered a panel of experts from Africa. They were education or first aid experts, or both, which was nice because we had a lot of diversity in our panel. And these came from 6 different countries in Africa. So it was really nice to have different contexts, because African countries all are different from each other. That was clear when we were talking about it, that in some countries some things are not done, whereas in other ones they are done. So we had a meeting in Johannesburg in November 2017. So what did we do there? We were for 2 days in a very small, dark room, but we tried to have some fun as well. So we looked at the educational pathway, which we already made, but then we went through it from the African context perspective. So we had them look, is that actually workable for you? Do we have to include other things? Do you think that it's not possible in Africa? And so we went through the educational pathway, and we also went through the findings from the education review. So I will start off with the educational pathway. Content-wise, they told us you have to add some topics, because in Africa, for instance, stings and bites is very common. We have snakes, spiders, scorpions, and children also need to know what to do, or at least recognize when someone is being bitten by a snake or a spider. The same for fever. They wanted that we included some general knowledge topics on fever, because they feel it's also important that a child knows that there's nothing wrong with someone who has a fever, that it's not, that they know how to recognize it and ask for help. Same for diarrhea, because it's very common in Africa. And one of the most important, well, the most interesting, I thought, was about fits, because there is a general belief in some countries that a person who has epilepsy is actually possessed by a demon or a bad spirit, or that's, if you touch someone like that, then you will get that also and go to hell, actually. So it was very interesting that these experts said we have to make sure that children know that it's not contagious, that it's not a bad thing, that these people are just ill. So we included that. And also they were very interested in how how to teach children what to do during a disaster, but a disaster can also be very small. Just yeah, at emergency situations, what should we do? How should we react? Also, not only did they thought that we had to add some topics, they also thought that we had to add some interventions within the topics that were also there. So splinting, for instance, is something that in Belgium we will never recommend to do, but they said, like, yeah, when you're 800 kilometers away from a hospital and you have to get somewhere with a broken leg, then we splint. And we're okay, and then we'll add this. As Liv already mentioned, we don't have gloves, so maybe we'll put something in about plastic bags instead. Now about context. This is more about where they put the E, K, and the R, so more about the age ranges. They said that seeking help from a medical care provider, as Liv already said, with us we can teach a child to phone 112 or 911 or 999, but there in Africa they have to go running after a post. They can be for miles, and it's more like a threshold which they have to cross, so that's why they said we should put it at a later age and keep repeating it, that it's necessary to seek help whenever you see someone who needs help. About hand washing, they said it's not that not that, how do you say that? Children aren't aware enough that they have to keep washing their hands, so they said you have to keep repeating it in the curriculum until 18 years of age. And then about touching an unknown person was in there for as an objective, a general objective, like you have to be able to touch an unknown person. There were a couple of people in the expert panel who said, like, you're not going to let a child go to an unknown person and touch him. Maybe he's like lying there, and is that actually an ambush for the child so that he will be robbed or something? And we were like, okay, we never thought about that like that. So then we removed this objective, and it's actually more the thing that the child will call from a distance. Are you okay? Can I help you? Are you, instead of being like touching the person for real. Also for burns, they had a nice remark, I think, that a lot of the burns in Africa are caused by fire and hot water, and that the children actually have to know that from a very young age, that it's very dangerous to be near an open fire or hot water when the mom is cooking, for instance. So they have to be very aware of the danger at a very young age, and the other causes of burns, it doesn't really matter. So we split up the objective into two separate objectives there. So I'm pleased to say that in the back of the room on the table, there's the final educational pathway. So it's a nice booklet which contains the entire educational pathway. So just some explanation on the pathway, and then you have the entire pathway, so on all the first 8 topics, which is contextualized to the African context. So during the panel meeting, we also had a discussion on educational methods. So this is a slide where we did an exercise with the experts. We had them think about which types of educational methods can you use in which age category. So you cannot really see it, but there's song, there's videos, there's mannequins, there's role play, etc. And they had to think which ones fit with which age group. So when I have to teach something, what can I use best? So that's what we did then. And we also had them make their own top 3 for each of the groups concerning the materials, because we are not sure yet what to actually develop for these children. And so we had them write it down, and we made like a small counting, so vote counting, and it revealed that actually they find games, storytelling, and songs the best ways to teach first aid to very young children. Songs, which is also not that common, I guess, in the Belgian Red Cross. We're not really, we're not tending to make songs, but in Africa, if it works, then we do it. Then for the 9 to 12-year-olds, it was case studies, games, and role-playing. And for 13 to 18 years old, role play, flip charts, and case studies, or the use of videos or mannequins, so to really exercise on. Now, what are we going to do with all of this information? We got the educational pathway, and we got these top 3s in educational materials. Now, currently, we're developing first aid educational materials for children aged 12 to 16 years old. So some of my colleagues are working on that, how to make some songs about certain topics. Yeah, that will be very interesting indeed. Then we will also use some African experts, because we're developing some stuff to make sure that it's very contextualized, so photographs, layout of the manuals or the posters or whatever we're making. And then in a second step in September, we will have the expert panel meet again to look at these materials themselves and give feedback again for contextualizing. And then, of course, the question, does it work? That's the most important, I think. We will start a pilot study in Zimbabwe and Burundi. So first of all, we will train the trainers, and they will give then first aid courses to children using these materials. So the thing is, how does that impact learning? We will measure that. We will also look what is the feedback of the children or of the trainers themselves on these materials. Can they use them? Are there things that we need to improve? And then by January 2019, the materials should be finalized and available to, I don't know.
Trainers.
The trainers, yeah, okay.
Sure.
So I just want to acknowledge, because it's a lot of work to do to screen all the, what was that? 11,000 studies. So I want to thank my colleagues at the Center for Evidence-Based Practice, and also the entire expert panel, which was a very nice gang to hang out with. And Aliva will talk, I think.
But maybe we do the challenges afterwards.
We can take the challenges last.
Then I'll give
yes.
the word to you.
And I would please ask you to hold your questions a bit as well, so that we can listen to the experience of Dr. Monica Aurora first.
Yeah, I don't know where it is.
Okay, so can you hear me fine? Great. So we have talked about contextualization in this session, and that's what I'm going to continue as the theme, but changing the topic a bit to diabetes. So in the audience, I would just like to check, has anyone in the group worked on school health programs earlier? Can we have people raise hands? Okay. Okay, school health programs. And diabetes prevention and management? Okay.
A bit.
All right, a bit. Good. So I know who I'm talking to. All right, so I work with Public Health Foundation of India, and I'm representing today International Diabetes Federation, which is based here in Brussels. And I'm going to present a collaborative project which was done by IDF, International Diabetes Federation, with Public Health Foundation of India, and it was also done in Brazil. So quickly to talk about diabetes as a burden. I'm sure I'll not get into epidemiology. We all know it's a growing burden, and world is currently grappling with non-communicable diseases, and diabetes is one of the very prominent ones under those NCDs. So I'll do a brief introduction. I'll go on to talk about the project, which is the KIDS project. Most importantly, what happens in school health programs and why it has not really caught on is the evaluation which is missing. So I'll talk about the importance of evaluation, main achievements that we saw under this project, and moving forward, what are the next steps. So what is IDF? Briefly, it's an umbrella organization of over 230 national diabetes associations in 165 countries around the world. And IDF is active in the following areas, as you see on the slides: advocacy and outreach, epidemiology and research on diabetes, educational programs, diabetes care, access and prevention, and humanitarian activities. So diabetes does bring with it a lot of complication. Therefore, the emphasis on prevention of type 2 diabetes is paramount for public health. Also talking about type 1 diabetes. So how many in the audience know the difference between type 1 and type 2 diabetes? Okay. I'm not surprised, because when we started this project in schools in Delhi, where school principals who are from elite schools and are supposed to know everything about health did not know what is type 1 and type 2 diabetes. To the extent, the stigmatization of type 1 diabetic children was to the extent that children who were diabetic, and if a child and the parents of the child who was non-diabetic came to know about it, they would not allow this child to share tiffin because they felt it was contagious. So that kind of myths did exist in very urban areas in Indian context. So talking about diabetes in children, so as is on the slide you see, the incidence of diabetes among children is increasing in many countries, and IDF estimates that there are about 1,106,200 children and adolescents who are suffering with type 1 diabetes worldwide. Now, type 1 diabetes, as many in the group would know, is not preventable, but can be managed. But type 2 diabetes is preventable. The incidence of type 2 diabetes is increasing rapidly among children and adolescents too. Earlier, the disease was among people who would be 40 and above. But now the trend is changing, and it is being seen in children and adolescents as well. Schools form a significant part of every child's life, and developing diabetes in childhood can negatively influence their school experience as well as their academic outcomes. So definitely school gets really interested when it comes to prevention of diseases, because we heard it in the morning, we know it's a win-win situation if we are able to prevent diseases and at the same time be able to see educational outcomes with single interventions or comprehensive interventions. Unfortunately, educational institutions in countries do not have support from clinical staff with expertise in diabetes or information and age-appropriate education resources. So many a times, a type 1 diabetic child would not be taken for school activities. It's because the teacher feels she's not capable of handling a type 1 diabetic child, and if any emergency comes in, she will not be able to handle that situation, she or he. Therefore, IDF has developed the Kids and Diabetes in School project to foster a safe and supportive school environment. So as you see, this is an overview of the Kids project. It aimed to focus both on type 1 diabetes, to be able to provide school with an environment and skills among teachers to be able to manage a type 1 diabetic child, school to have policies which are supportive of having a type 1 diabetic child, but also for type 2 diabetes involving all the children in the school, so that it's an all-embracing program and not for only type 1 diabetic children. To raise awareness of diabetes and benefits of healthy diet and physical activity among school-aged children. We know in the school setting and dealing with children that behaviors get etched very early on. Therefore, interventions have to start before these behaviors and their choices are formed. So to prevent type 2 diabetes and to have a healthy lifestyle, interventions were started with children as young as 6 years old. So our target audience was children in the age group of 6 to 14. And we also included in the program teachers, school staff, nurses, parents, all stakeholders who are in the vicinity of this child. Key strategic partners included ISPAD, Sanofi, IDF for sure. Local partners in Brazil and India were AJD, Public Health Foundation of India, All India Institute of Medical Sciences, Hriday, an NGO working with the schools and adolescents. So having all these partners come together to design a global program, which was then culturally translated for the two countries, Brazil and India. And I'll go through the process of how this contextualization was done, but the intervention had to be for this wide age group of 6 to 14, so age appropriateness also had to be ensured. And also close association that we find between both type 1 diabetic child as well as type 2 type 2 diabetes prevention. The common intervention has to be a healthy lifestyle. So that was identified to be the common theme. But key activities, as you would see, as my earlier speakers also said, didactic lectures would not have translated to behavior change. We could have given knowledge, but behavior change required a bit more of participatory activities. So school awareness activities, trainings, workshops, events, innovations, how the same information can be made interesting for children, engaging with policymakers, educational and health authorities so as to be able to include this program in the school environment and get permissions to be able to test it in schools, and also to make the activities, information pack, leaflets, videos interesting. So this was our phase 1, where an international pack was created by IDF under the guidance of an international advisory committee, which included experts working in the area of diabetes prevention, as well as working in the area of school health. So these materials were developed in English. You would see that the second picture that you see is how it has been contextualized. So it was context relevant. That is, the food items, for example, which was listed had to be changed by countries. You would see the dressing of the teacher. It has to be culturally sensitive. Age-appropriate text. And the most important was the materials need to be comprehensible. So language translations. For India, in Delhi, we have Hindi as a language spoken. But for Brazil, it was Portuguese. And still, we needed in India more language translations because every state has a different language. So we have like 16 official languages, but we could not do it for all the states. However, we did it for English and Hindi, at least to be able to cover the northern belt in India. Also, the experts that came together to do the cultural translation were multidisciplinary experts, including stakeholders like endocrinologists from the premier institutes, medical institutes, but also the National Council for Educational Research and Training, which is the apex body at the national level that designs curriculum in schools. So they were brought on board. So it was a truly multi-sectoral group bringing the education and the health department together, but also the target audience. Children and teachers were also included in this stakeholder consultation. So if we don't have the target audience in this adaptation process, we are not able to speak the language that they understand. Moving forward, these are how the sheets that you see are translated. And most importantly, there was a comic strip which was included because these booklets were to be given not only to the teachers, but you see there are 4 booklets. It's for teachers, for parents with diabetic children, and for children. So we had 4 kind of booklets created to be able to really talk to the target audience that we are wanting to reach out to. And the comic strip was common. And when we did our evaluation, what they recalled was this comic strip. They remembered the protagonist's name. They could list out all the activities in that comic strip. So that is what stayed with them for a long time. Talking about phase 2 of the implementation, so once these booklets were designed, just information given in attractive format would lead to, okay, their understanding. However, to be able to inculcate those things in their behavior and bring about a behavior change, we had to do these participatory activities. So after teachers were trained, students' engagement was started by doing participatory classroom activities, role plays, games in the classroom to be able to reinforce the messages. Inter-school competitions were done for doing street plays on diabetes to be able to give out those messages to the community. Street plays are very common in India as a means of communication when you want to really bang on an issue and make sure people understand it. And poster making competitions so that they have their own resources put up in their own school and there is ownership of the issue. I can talk to the child, but if there is no ownership for that issue, they will not identify and retain that information. So that ownership is very important for behavior change and to have a long-term behavior change implemented. Also, what is it in for teachers? Teachers would feel this is another burden. They have to catch up with their curriculum. So what is it in for them? We provided hands-on training for teachers. Simple thing as use of a glucometer was something that teachers were not comfortable with. And when we did the training for teachers, they felt they were getting empowered. There was skill building for them. So we had to do some of those adaptations when we implemented at the country level. And also social media component was introduced because this was being done in an urban setup. So parents wanted to connect with other parents having diabetic children, be able to share experiences, be able to share recipes, activities, and the like. So a support group was created, online contests, polls, and promoting the downloading of this whole kids pack was ensured through these implementation activities. Most importantly, government was intrinsically involved right from the phase 1 of this study. So government, including both Ministry of Health and Education, were brought on board as working group members. So when I said an expert group was put up, we did have people from the school health scheme from the government come in and join this expert group, as well as we had from the education department officials joining us and the Ministry of Health joining in development of this package. Permissions had to be sought from the Directorate of Education to enter any school. So those appropriate permissions were sought, and again presentations were made to these departments as to why such a program is relevant. The launch of the program also saw key officials coming and discussing the whole issue of diabetes awareness in the school setting, and it included people as high as deputy commissioners from the federal government to people from school health scheme, and under the national apex body there are training bodies of teachers which is called the SCERT. They do trainings of teachers at the state level, so even they were engaged so that centralized trainings can be done for the teachers and not going to each school and doing those trainings. So teachers are usually trained in a organized manner. As was said in the morning, they have a system in which they do their trainings of teachers, and that's how we need to include our programs alongside those ongoing structures which are in place and use them to the best. And also currently the program continues to be informing a lot of government programs. So Food Safety and Standards Authority of India has taken, they are starting a program on safe and nutritious food, and they have taken the kids pack on board to be included as part of their program. In Brazil, the phase 1 involved again similar process of introducing the project to the stakeholders, including health, education department, bringing NGOs on board, and scientific societies. The phase 2 had selection of schools, so they widely advertised schools that wanted to join this intervention. And this also involved reaching out to the teaching offices in the state of Sao Paulo, NGOs in diabetes, media of communication on the ADJ website was used to announce that there are schools who are interested can join, but also emails for the network who were ADJ members. They also received emails to be able to join this intervention. The pre-implementation training in Brazil included educational materials as it was adapted for Brazil and translated into Portuguese. These were given out to nutritionists, nurses, physical educators, physicians. Young leaders also participated in the training. So there are children who are diabetic and have been trained to become youth leaders so that they can share their experience on how they manage their diabetes effectively. That becomes a very important testimonial for parents and other young leaders. So when we did the launch event, we had these parents talking to each other, children talking to each other, and feeling comforted that yes, they can have a very managed, well-managed disease, even if they are going through a rough patch. The fourth phase in Brazil was, again, participatory activities, student engagement, presentation of kids' educational packs in interactive, dynamic manner, and activities with the school staff and families of the students with diabetes. This was like a 1-hour session engaging the parents who had children with diabetes. So it is important to engage this one individual in a social ecological model. As we see, this one individual has another layer of social environment which is around them, so influencing that environment through the school setting as well as influencing the family, so bringing parents on board. And the third layer, which is of the policies, how to make policies supportive so that this behavior change is sustainable. These are some examples of the implementation in Brazil. So you see there have been teachers trainings, media launch as well in Brazil, which was an added component for Brazil, but also having meetings with Sanofi, which was a funder, at the same time a partner. Brazil did identify some of the challenges, and here I would like to ask people who have worked on school health programs, what kind of challenges identify with what has been listed here. There have been, it's difficult to bring education ministry and health ministry together on a coordinated platform. So I'm sure we all who have worked in this area know, and we saw in the morning on the opinion poll, it is a complex issue. School staff had trouble taking part in educational training sessions. So many a times it so happens when we want all the teachers to be trained, school has a lot of problems sending 20 teachers for that kind of training. So we have to look at logistic issues. School had trouble engaging the students' family members because they have their own priorities, their own schedules. They may not want to come to school for a training or interaction because they have their own things going on. And school staff had issues regarding being responsible for a student with diabetes and their family members. So they did not feel that empowered to be able to take it forward, which also means that they require extra hand-holding, and continuation of these sessions is important. Also, In India, some of the challenges were only around language translation. We were lucky enough to bring education and health to talk to each other. So this is again very context specific. Some things work in a particular context, but as it translates into another context, the environment and other determinants do play a very important role. But when we tried to implement it in another state, like Aurangabad and West Bengal, we did get requests that apart from English, they need materials in other languages as well. So after implementation, it was important to evaluate, and I would recommend anyone who's going for any kind of intervention to surely include evaluation in their programs. And as was said this morning in the plenary, again, gone are the days we don't need to do an expensive randomized controlled trial. Process evaluations are very good, and that's what we did. Our evaluation was semi-structured face-to-face interviews. We included it, we did it with teachers, with children, with parents, and also both in Brazil and India, similar methodology. So we had common interview guides which were used, and in terms of outreach, we already see that 1,400 school staff, both in India and Brazil, and almost like 38,000 students were reached out through this program in our 2 years of intervention and evaluation. Under evaluation, our key objectives were to be able to assess the experience and satisfaction with the kids' project intervention through interviews. So we do not need to show that there is a change of knowledge in intervention school versus control schools, because that is what we traditionally do in RCTs. However, here we wanted to see more of what was the experience they are having. We all know giving intervention in schools is beneficial. We don't need to produce any more evidence on that, but it is important to understand what works for whom in what context. So that contextualization is very important in the current field of science. So talking about what we found, definitely there was change in their knowledge and their behavioral skills about diabetes and maintenance of healthy lifestyles. Teachers as well as parents reported that there was increased knowledge. They were changing their behaviors. There was greater understanding about diabetes, symptoms, and treatment. They were able to deal with hypo and hyperglycemia. They knew the importance of eating healthy, and also parents of children without diabetes, they too gained new knowledge through this pack which was given to them. They felt the need to make lifestyle changes to reduce the chance of type 2 diabetes. So that prevention intervention did help them think about whether they too need to make a change. In terms of quality of care and support for children with diabetes, again, very positive results throughout. There was greater confidence in the school staff. They changed their own behavior in order to improve their lifestyle. So they felt that if they are the messengers of a health intervention, how can they be eating unhealthy in presence of children in the school environment? So they felt they also wanted to change their own lifestyle. And many a times they went for their screening for the first time. They had not got screening done for diabetes till that time. Level of satisfaction with the information pack, they felt this was a very high level quality material which was produced. It was appealing and interactive and useful for seeking information on diabetes. It was also a high level of satisfaction due to clarity and accessibility of the information. So you would see there are materials at the back. There are thin booklets, pictorially depicted, so that they have to read less and they can understand more with key concepts which were given in those packs. Impact on the school environment as well. School staff felt there was increased interest in the subject of diabetes in the school from where they did not know the difference between type 1 and type 2. There was an increased understanding. Healthier food options were now being served in the school canteen. So policies changed that school canteens were not serving the fried food, and there were healthier options that were given. And this was well embraced because children too agreed with those. Children were involved in these decision-making processes, and they were given in the activities, what would you design your canteen menu to be? So that was what changed the whole ownership of the issue, and not only changed the school environment, but messages went back home, and eating at home also started changing, with parents reporting that there was involvement in the care of child with diabetes. So parents were more open to the school staff now and could offer suggestions on how they felt their child can be better looked after if he is a type 1 diabetic child. Just quick quotes on the final evaluation. So there were a lot of very encouraging testimonials, but in India, one important quote from the teacher was, "I came to know about type 1 diabetes and type 2 diabetes. We knew only the basics of it, but in-depth knowledge I got to know from your session and resources." And in Brazil, one of the quote was, "You explained in a few pages with easy language everything you need to know, no technical terms. I left it in the bag. It was a manual. It was easy and gave a great support for us. I liked it." So these were very encouraging to see that materials which were evidence-based, prepared by science and then implemented following health promotion theories, were well accepted and contextualized both for India and Brazil, and were well received. So just a quick example of testimonial of a teacher who implemented this in Delhi.
Good morning, I'm Bharti Pant, teaching science to the secondary classes in DLDAV Model School, Pitampura. At the very outset, I want to thank Hriday for launching Project Kids in our school. This project has been very helpful for all the stakeholders, as it has given tremendous information to students, teachers, parents, and all the stakeholders about diabetes. The launching of this project has made tremendous change in our various activities of the school. Type 1 diabetes students are identified as many as 4 students in my school. Many more such workshops in the future to have this great information. It will be a great help to the society.
This is a testimonial of a mother from Brazil. She could clearly see that there was lack of information about the severe dangers of hypoglycemia. She took the materials, all the materials were on ADJ website. So the kids' materials were downloaded, and these were shared with the school to be able to use these materials in the school setup and benefit from it. The professionals in the school felt more confident and prepared to take care of my son during the time he remains there. I'm very grateful for the materials that were provided by ADJ. So these were both from teachers and parents coming in support of the kids program. The main achievements of the program currently are that the information pack is available in 13 languages on IDF website. It's in Arabic, Chinese, English, French, Greek, Hindi, Japanese, Polish, Portuguese, Russian, Spanish, and Urdu. Around 7,800 teachers and over 60,600 children have been trained as of December 2017 on kids program around the world. Engagement of the health and education policy makers has been seen in various countries. There have been various scientific abstracts which have been submitted and presented from this project in various conferences. Over 16,000 downloads of the kids information pack have happened, and these have been again from downloaded by various stakeholders, not just parents, teachers, to the extent that there are medical professionals as well who are downloading these materials. Kids app is also available in 8 languages. It is available for tablet and iOS as well as Android platform. Guidelines on how to use information pack are also available for facilitators, just in case we don't have trainers to train teachers. This guidance is available. Final evaluation completed in the 2 pilot countries, India and Brazil. And 60+ countries engaged with the kids project, currently using all the materials which are available on the website. There are some complementary resources which were created in India and Brazil both, because the evaluation did bring out what are the gaps they feel. They still feel they need more resources, and both the countries are working towards that in creating more resources. For example, teachers training, they wanted an endocrinologist to do a teachers training in the setting. India recorded 10 minutes of such a session with a renowned endocrinologist in India. I will not play those videos, but one video from Brazil, which is an additional resource.
A gente quer mostrar para as escolas que dá para lidar com diabetes de uma forma diferente. Diminuir um pouco das fantasias em relação a como que eu vou cuidar dessa criança e não ter esse medo. Então, o programa ele tem 2 momentos. A gente vai ter o treinamento com os profissionais que atendem o aluno com diabetes.
Quais sintomas que esse aluno pode ter se ele tiver numa hipoglicemia, numa hiperglicemia? O que é exatamente o diabetes? Que tipo de intercorrências podem ocorrer durante o período de aula? São pequenas coisas.
There is translation, but I don't think it is very visible. Yeah, so I think I'll move on. In terms of training and educational activities, we need to, engage teachers. Has been our experience that teachers are very effective delivery messengers when it comes to both India and Brazil. We had very good support for messages coming from teachers because they are seen as to very authentic source of information for children. But also at the same time, the peer-to-peer interaction is valued equally, so it is important to identify a few champions. And the online training in Sao Paulo, as well as having media engagements, dietitians trainings, were some of the activities which were contextualized for Brazil. In India, there were other contextualizations, as I have explained, but again, countries decide on their own what would work in their context for such an intervention. So moving forward, what needs to be done and what is happening is policies and programs, including the national NCD program in countries like India, they need to strengthen the type 1 diabetes component. Currently, in India, the national program is very focused on type 2 diabetes, and with this program, we were able to prioritize it for the government at the federal level. Health promotion strategies for diabetes prevention and management need to start from a very early age. Both education and health need to work collaboratively in implementing the health promotion curriculum. Training and engagement of teachers and parents is crucial for success of these initiatives. If parents are not engaged, they are the ones preparing food at home, and if the intervention is just left to the child, this will not translate into behavior change or in their practices. Therefore, engaging parents was equally important. Guidelines regulating foods are available now in the school setting. Policy on physical education in the school setting is being seriously looked into. Even though it was on paper, it was never implemented, but kids did help them understand that it is important for children to play alongside, be able to complete their curriculum. tailoring resources for different audience and cultural adaptation, as we had seen for both the countries, and scaling up and intensifying kids' intervention to other regions. We have recently got a grant to be able to do a more comprehensive NCD intervention in the school setting in India, and we are including this kids' diabetes under that because we have something which is tried, tested, and evaluated. Also, it was found that nutrition education in school needs to be further emphasized, and IDF has come up with a set of these new educational guide on nutrition and diabetes in children. This is complementary to the original kids information pack. So there is an educational guide on nutrition and diabetes in children. There is nutrition guide for parents of a child with diabetes, and nutrition guide for parents in general to be able to have children follow this, and nutrition guide for children themselves. And we have extra copies here, and those who are interested can please pick it up. Just to conclude my presentation, I will recap the 3 key messages that we have learned in this program. Contextualizing a global intervention requires experts to be brought on board as well as target audience. They need to sit around the table and contextualize the intervention. Teachers are key messengers, and it is important to engage them as well as peer leaders. But most importantly, make school health promotion programs participatory. That is key. And I would like to end with a famous quote. If we have to engage children, it is, "Tell me and I forget. Teach me and I remember. Involve me and I learn." Thank you.